ಚಂದ ಐತಿ ಚಂದಿಲ್ಲ ಇದು ಕಾಣ್ತಿದ್ದ ಫಿಟ್ಟಿಂಗ್ ಮಾಡ್ಸ್ಕೊಂಡು ಫಿಟ್ಟಿಂಗ್ ಹಿಂಗ್ ಫಿಟ್ ಕೂತಂದ್ರೆ ಕರೆಕ್ಟ್ ಆಗ್ತೈತೆ ಫಿಟ್ ಆಗುತ್ತೆ ಇದು ಮೇಲೆ ಹಾಕಿದ ಫಿಟ್ ಆಗುತ್ತೆ
ಯಾಕಂದ್ರೆ ಅದರಿಂದಲೂ ಬೀಳುತ್ತೆ ಅದು
ಇದನ್ನ ಹಾಕೊಂಡೆ ವಾಷಿಂಗ್ ಮಾಡ ಫಸ್ಟ್
ಎಲ್ಲ ನೋಡ್ಬಿಡ ಒಂದ್ಸಲಿ
ಮ್ಯಾಗ ನೋಡ್ಲಿ
ಇಷ್ಟು ಸೈಜ್ ಹೊಸಗುಣ ಇದು ಹಾಲು ಇದು ಊಟನ ಏನ್ ಮಾಡಿ ಬಾಬು ಊಟ ಊಟ ರೆಡಿ ಕೊದ್ವು ಜಾಂಬೀಸ್ ಅದ ಫೈಟ್ ಕೊಡು ಊಟ ನೀನ್ ರಾತ್ರಿ ಹಾಲು ಖಾವೆ ಡ್ರೈ ಡ್ರೈ ಡ್ರೈ
ಫಸ್ಟ್ ನಾಕು
ವರ್ಷ ಮಾಡ್ತಾರೆ
ಖುಷಿ ಮಾಡ್ತಾರೆ
ಮಾಡಿಸ್ಕೊಂಡು ಮತ್ತೆ ಬಂದ್ ನೋಡ್ಬಿಡಿ ಇದು ಸ್ಕರ್ಟ್ ಸೈಜ್ ನೋಡಿ ಇಲ್ಲಿ ಸ್ಕರ್ಟ್ ಸೈಜ್ ಇಲ್ಲಿದ್ರೆ ಗೊತ್ತಾಗುತ್ತೆ ಇದು ಹಾಕೋದೇನ್ ಬೇಡ
ಆದ್ರೆ ಹೆಂಗ್ ಕಾಂತ
ಇದು ಜಸ್ಟ್ ಇದು ಕಟ್ಬೇಕಷ್ಟೇ ಇದು ಈಸಿ ಜಸ್ಟ್ ಸೈಜ್ ಇಷ್ಟೇ ನೋಡಿ ಇದು ಕರೆಕ್ಟ್ ಆಗುತ್ತೆ ಕರೆಕ್ಟ್ ಹಾಕುತ್ತೆ ಇದು ಅದು ಇಲ್ಲಿ ಬಿಡಿ ಅದೇನು ಆಲ್ಟರ್ ಮಾಡೋದೇನಿಲ್ಲ ಇದು ಜಸ್ಟ್ ಸೈಜ್ ಮೇಲಿಂದ ಅಷ್ಟೇ ಇದು ಸ್ವಲ್ಪ ಅಂದ್ರೆ ಫಿಟ್ಟಿಂಗ್ ಆಗಿಲ್ಲ ಅಂದ್ರೆ ನಡೀತಾ ಇರ್ತಾರೆ ಅದು ಆಗಿರ್ತಾವಲ್ಲಿ ಕರೆಕ್ಟ್ ಸೈಜ್ ಇದು ಮಾಡ್ದೆ ಅಂದ್ರೆ ಹತ್ತದ ಹತ್ತದ ಫಿಟ್ಟಿಂಗ್ ಏನ್ ಬರ ನೋಡಿ ಅಲ್ಲ ಕರೆಕ್ಟ್ ಇದೆ ಕಿಚನ್ ಇದೆಲ್ಲ ಹಂಗೆ ಇರುತ್ತೆ ಇಲ್ಲ 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 ಝೂಮರ್ ಹಂಗೆ ಇರುತ್ತೆ ಅದು ರಾಜಸ್ಥಾನಿ ಡ್ರೆಸ್ ಅಲ್ಲ ಕರೆಕ್ಟ್ ಇದು ಏನ್ ಫಿಟ್ಟಿಂಗ್ ಏನ್ ಬೇಡ ಅನ್ಸುತ್ತೆ ಅಲ್ವಾ ಫಿಟ್ಟಿಂಗ್ ಏನ್ ಬೇಡ ಬೇಡ ಸರಿ
ಅವ್ರ ವೇಲ್ ಹೆಂಗ್ ಹಾಕುದಂಗ
ವೇಲ್ ಹೆಂಗ
ಅದು
ಈ ತರ ಹಾಕ್ಬೇಕು ತಲೆಗೆ ಹಾಕ್ಬೇಕು ಕ್ಲಿಪ್ ಹಾಕೊಂಡು ಇಲ್ಲಿ ಇದು ಇರುತ್ತೆ ಅದ್ರ ಅದು ಗುಮ್ಮಟ ಇದು ನೋಡಿದಿರಲ್ಲ ಹಂಗೆ ಹಾಕ್ಬೇಕು ದೀಪಿಕ್ ಮಾಡ್ಕೊಂಡು ಹೆಂಗ್ ಹಾಕ್ತಾರಲ್ಲ ಇದು ಜಸ್ಟ್ ಘಾಗರ ಅಷ್ಟೇ ಇದು ಅದೇ ಡಾನ್ಸ್ ಹಂಗೆ
ಇದು ಬೇರೆ ಅದ್ರ ಜೊತೆ ಅಲ್ಲ ಸಪ್ರೇಟ್
ಸಪ್ರೇಟ್ ಅದು ಇದ್ರ ಜೊತೆ ಅಲ್ಲ ಇದು ಬೇರೆ
ತೋಟ ತಂದಿದ್ರೆ ಚಂದ ಕಾಣ್ತಿತ್ತು
ಹಾ ಇದಲ್ಲ
ಹಿಂಗ ಈಗ ಆಕೆ ಹಾಕೊಂಡ ನೋಡ್ರಿ
ವರ್ಷ ಇದು ಒಂದು ಮೀಟಿಂಗ್ ಇದೆ ಅದಕ್ಕೆ ವರ್ಷ ಮಾಡ್ತೀನಿ ನಾವು ಇದು
Hello, good evening all. Good evening everyone. Can you hear me? Can you hear me?
Yes, welcome.
കേൾക്കാം അനിത ജോയിൻ ചെയ്തു അല്ലേ സുജമോൾ മാഡത്തിനെ കാണുന്നുണ്ട് ഗുഡ് ഈവനിങ് മാഡം കൂടുതൽ ആൾക്കാരെ ജോയിൻ ചെയ്യണ്ടോ തോന്നുന്നു
നമ്മളത് മ്യൂട്ടാണോ? ഓക്കെ ഓക്കെ ഓക്കെ.
മിനി ജോയിൻ ചെയ്തോ? മിനി കേക്കണ്ടല്ലോ അല്ലേ?
കേൾക്കാം കേൾക്കാം.
ആ, ആ.
ഇതായിരിക്കും.
ഭാവം എപ്പോഴും നമ്മുടെ കൺമുമ്പിൽ ഉണ്ടാവണം. ഞാനൊരു ഭാവിയാണെന്നുള്ള ബോധം എപ്പോഴും നമുക്ക് ഉണ്ടാവണം. വിശുദ്ധ പൗലോസ്ലീഹ പറഞ്ഞു, ഞാൻ ഭാവികളിൽ ഒന്നാമനാണ്. വിശുദ്ധ പത്രോസ്ലീഹ പറഞ്ഞു,
ജ്യോതി മാഡം ജോയിൻ ചെയ്തിട്ടുണ്ടോ?
Yes, I'm here.
ആയിക്കോട്ടെ. ഞാനിപ്പോ ഫോൺ വിളിക്കാൻ നിൽക്കാണ്.
Good evening, Reshma. Good evening,
ഗുഡ്
everyone. Hi,
നമുക്ക്
Anita.
സ്റ്റാർട്ട് ചെയ്യാം അല്ലേ? ഗുഡ് ഈവനിങ് എവ്രി വൺ. ആർക്കും ഇപ്പോൾ everyone is so busy with their own work, with too many webinars, maybe 2 or 3 sometimes per day. So bombarded with too many knowledge, but we want to know which is the best for us, what we can take into our clinical practice. അപ്പം ഇന്നിപ്പം വേൾഡ് ഡൗൺസ് ഡേ എന്നൊക്കെ പറഞ്ഞിട്ട് there are so many celebrations going on, but I don't know whether it is a day to celebrate. But what I am reminded today is, today morning when I went for rounds, one of the patient who underwent staging laparotomy 3 days back, who visited our OPD for 5 times. I spoke with them. I spoke with her son, and during surgery, before surgery, she was here, and now today she was asking why uterus is being removed. You didn't tell us regarding removal of uterus. So that is the problem. I had written everything regarding explanation. I have told the bystanders everything. So that is the problem nowadays. And now when, especially in ultrasound and all, when we see so many reports, many obstetricians like me are in a dilemma, especially when we see something like an echogenic intracardiac foci or a choroid plexus cyst. So many things, we are still in a dilemma. We just refer it to doctors like Jyoti ma'am and Anita and all. But we want to know really what we have to do, whether we are apt doing the necessary things, all these things. We want something to be taken to hospital, not home, to hospital to practice. So I think today's true topic, it is very important for us. So I wholeheartedly welcome Dr. Jyoti Mancheri. She needs no introduction for us, because we have been seeing her. I have been seeing her right from Calicut, always with a smiling face. Wherever we see her, she comes and talks to us. So
Okay. Thank you very much, Reshma, for the kind introduction, and good evening, everyone.
actually, one CV slide was there, which I wanted to show.
You can screen share it.
Yeah.
Do you want me to screen share?
If you could. I think it's visible now. Yeah, Jyoti ma'am has too many degrees into her credit, and she's she's senior consultant in fetal medicine, N-Care IVF Aspire Children's Specialty Center, Mitra Hospital, Calicut. She's president of Society of Fetal Medicine Kerala Chapter 2024 to 26, fetal medicine coordinator of KFOG at present, author of chapter in textbook Essentials of Perinatology, reviewer of various journals in obstetrics and fetal medicine, invited speaker, we have seen her, and organizer of various conferences, and former lecturer in James Cook University, Townsville, Australia, and former consultant in charge prenatal diagnosis and high risk obstetrics, Mackay Base Hospital, Australia. So we know she has too many things to tell us. So I hand over the screen to ma'am. Kindly
Thanks, Reshma,
proceed.
again. So, good evening, everyone. Let me screen share mine. Can you stop sharing, Reshma, so that I can share mine? Yeah.
Are you able to do it?
I'm trying. Somehow it's not coming. Let me see. Please let me know if you can see my screen.
Yeah, we could.
Can
It's
you?
full screen. Yeah, definitely. We could
Right.
see.
So I think it's an honor to talk on a particular topic on this special occasion, which is very close to my heart. Okay, so as Reshma has rightly mentioned, today is World Down Syndrome Day. And you know why we not celebrating though, celebrating this particular day, because it's 21st March and it represents 3 sets of chromosomes on the 21st position. And way back in 2012 onwards, we've been celebrating this on 21st March. So to start the topic, way back in 1866, John Langdon Down is the one who observed that babies with mental retardation had loose skin and small nose. And that is where we started our ultrasound screening for Down syndrome. So from 1866 onwards, it took another 100 years for us to identify the actual reason for Down syndrome as an extra chromosome on the 21st position. So this is just a timeline of the event happened before what we have at the moment. So another 10 years, we identified that we can pick up Down syndrome when the baby is in the uterus by doing amniocentesis. From 70s to 80s, we had only age-based screening. There was no other screening. And believe me, this is age more than 35 offered amniocentesis. It's not like a methodology of screening. It is for the diagnostic testing. We used it as a screening. From 80s to 90s, started having alpha-fetoprotein and second trimester screening. From 90s onwards, there is an exponential improvement in the screening program in the way of scan-based and biochemistry-based screening program. And 2010 is the phenomenal change of identifying NIPT, which is in par with the diagnostic test with a detection rate of 99.5%. So why are we talking about Down syndrome? Because it is the commonest cause for congenital mental retardation with an incidence of around 1 in 800. Compared to your trisomy 13 and 18, we are more worried about trisomy 21. The reason being they have a long life expectancy. So it is a huge burden for the family as well as the society to support them. And we know that Down syndrome does not have a cure. We can only modify their lives by giving them therapy. The purpose of screening is to identify it at very early gestation so that we know that a significant number of parents would offer termination if they know that the baby is suffering from Down syndrome. Even if they do not want to terminate, they would know it so that they can prepare themselves to handle such a baby. And our agony is that we cannot identify all Down syndromes purely based on ultrasound scan. Whereas in 13 and 18, you get to see at least some abnormalities in most of them, and they do not have such a long life expectancy. So that is why we focus on Down syndrome all the time. So moving on to the screening methods. What are the screening methods available? So these are the platforms available. One is age-based, where you decide whether she's low risk or high risk based on maternal age, which is not used anymore, because if you use that method, you can only pick up 35 to 50% of the Down syndrome. Now we will do ultrasound-based and biochemistry-based. So what are the ultrasound-based screening methods available for us at the moment? In the first trimester, you have your first trimester markers, your nuchal translucency, nasal bone, ductus venosus, and tricuspid regurgitation. If they come in the second trimester, you have all the soft markers like your nuchal fold thickness, your echogenic intracardiac focus, your ventricular megaly, and all those soft markers. These are the ultrasound markers. What about biochemical markers? In the first trimester, the most popular one is double marker, which is PAPA and beta HCG. And you have more and more markers getting added to this as the day goes. And the last one is genetic test, which is a cell-free DNA method, which is NIPT. So these are the available platforms. At the moment, the most popular one is combined screening. The reason being, it is the most affordable and most accessible one with a high reproducibility. So what is combined screening? You all know that. It's maternal age, nuchal translucency, PAPA, and beta HCG. So this is the universally accepted screening for Down syndrome. But people do different things, because if you have more markers available, you can add, it will actually improve the detection rate and reduce the false positive rate. So combined screening, even though it is popular, among the fetal medicine consultants, what we practice is first trimester quad screen with an added advantage of preeclampsia screening as well. Here we are adding PLGF and AFP to the double marker platform. So it will give you 89% detection with a 1.4% false positive along with preeclampsia screening. So which is the best if the patient can afford and if it's available in your area. So how do we choose? For your women, how do you choose screening methods? So you ask the age of the woman. Is she less than 35 or more than 35? What is the gestational age at which she presents? First trimester, which is between 11 weeks to 13 weeks and 6 days, or after 16 weeks or after 20 weeks. Whether she's got any previous history of Down syndrome or any other aneuploidies, and whether she is single, multiple, not higher multiples. So these are the questions you have to think when you are choosing the right method. So if a lady is less than 35, no previous history of Down syndrome, she's got a singleton or a twin pregnancy, and if she presents between 11 to 13 weeks, the best available test is combined first trimester screening. But you have to make sure that the crown rump length is between 45 to 84 millimeter on the scan. It's not LMP based. It is purely based on the ultrasound dating. So if that is the case, you can offer combined first trimester screening. Same lady, if she comes at after 16 weeks, then you can do quadruple test. I hope it's clear. So if a low risk woman presents in the first trimester range, you offer them combined first trimester screening. If they're present after 16 weeks, you offer them quadruple test. Next thing is, what if they're present between 14 to 16? This is a daily agony for me, because the validation of quadruple test is, and the detection rate is based on the gestational age. If you are doing the blood test at an early gestation, the provided detection rate is not going to be in par with what is mentioned. So always wait till 16 weeks, or if you have a scan, make sure that the biparator diameter is more than 31 to do the blood sample. Please do not send the biochemistry for quadruple test just because they missed the first trimester screening by around 14 weeks. This is what happens every day. So please make sure that send them home, bring them back and tell them that at 16 weeks, you can have your quadruple test, which is ideal. Triple test is not done anymore, because if you add one extra marker, your detection rate is going to be 10% higher. What about NIPT as a primary screening? I will not talk much about that because my co-speaker is going to talk about NIPT. But here, as a primary screening, now the trend is that everybody is having NIPT because this is the best test. This is not the best test, it's the most accurate test. Okay, so if the lady is more than 35 years, or if she has previous history of Down syndrome, whether she's singleton or twins, you can offer her NIPT. Otherwise, as a primary screening, you do not have to offer NIPT, because doing an NIPT and later on having problems is a common situation in our clinic at the moment. And make sure that if you are giving an IPT sample, make sure that they had a thorough anatomy evaluation and you have excluded possible anomalies at that gestation before you send it. Because if there are fetal anomalies, you cannot do an IPT. What if they're present after 20 weeks? If they come after 20 weeks for the first time, you cannot do quadruple test, you cannot do combined screening. The only thing which you can do is either genetic sonogram with a detection of around 60% or an IPT if they can afford. Again, there are situations where you can only do genetic sonogram. If you have anything more than twins, you cannot do any of these screening methods. So you have to offer her genetic sonogram. Or if she did not have any screening, and if she is falling in the high risk group, like your age wise or history wise, you can offer her NIPT. So when you send the sample for testing, how do you counsel a woman? You have to tell her that your age-related risk is such and such based on this chart. And tell her that this combined first trimester screening will look for only 3 common aneuploidies, trisomy 21, 18, and 13. Because people generally think that once they have double marker, they have sorted all the genetic problems in their life. So that is exactly what they ask. Even if I tell them that there's a cardiac anomaly, but we had Down syndrome screening, that's what they say. So tell her that this is the purpose, and you can see only that. And quadruple test will look for only trisomy 21 and 18, not even 13. Low risk means the chances of baby having abnormalities or Down syndrome is low. That doesn't mean that baby cannot have Down syndrome because it's a screening test. High risk means there is a high chance, but not the baby is going to be affected. And for your information, false positive and false negatives are possible. And positive predictive value of Down syndrome screening is only 4 to 10% for combined first trimester screening. What that means is, if you are sending me 100 women with abnormal combined first trimester screening or high risk screening, for only 4 to 10 will have actual problems. So if you send 100 patients to me over 3 years, your chance of seeing the Down syndrome coming back to you is only 4 to 10%. Okay, so no definite decision can be made based on the screening test. Even now, people come and ask me, screening is positive, can I have termination? The answer is no, because screening is screening, it's not confirmation. If screening is positive, you have the option of doing an IPT or invasive testing, depending on why screen is positive. And you have to tell the woman that being a genetic condition, it does not have any cure. Because that's another thing. Most of the people think that once we identify, we can treat it. The other important thing is assigning the age in oocyte donation program. IVF is rampant at the moment. So a 45-year-old lady who had an IVF conception with oocyte donor, please do not put 45 as her age. You have to actually put the age of the donor. And it's difficult. Sometimes you may not get the age of the donor. Then you can contact the center and ask them what is the highest cutoff for accepting donors in that particular institution. And you can put the highest number. You probably might overdiagnose, but still you will not miss Down syndrome. So after that counseling, then you'll do the nuchal scan. So what are the components of nuchal scan? You look at the nuchal translucency, nasal bone, ductus venosus, and tricuspid regurgitation. The percentage mentioned here is actually how many percentage of Down syndrome will have these abnormalities. What you should realize is that from NT 70 to 75 means 25 to 30% of the Down syndrome babies will have normal NT. Similarly, all the parameters, 30% of the Down syndrome babies will have a beautiful looking nasal bone. So if you see nasal bone or normal NT, that doesn't exclude Down syndrome. That's why I said you cannot exclude Down syndrome purely by ultrasound. Then you, as a routine, you look at the heart rate, biometry involved in the BPD, HC, FLAC, etc. Then you do a thorough anatomy evaluation of the baby, fluid, placenta, cervix, and of course, uterine artery Doppler, which will give you a score for preeclampsia as well. So these are the components of nuchal scan. So when you send patient for nuchal scan, please request your radiologist or fetal medicine or whoever is doing the scan to get all this information, because that's the right time to get all this information. So this is head-to-toe examination. I'm not going into the details. So when we see the fetus at 12 weeks, we try and mimic the TIFA scan as much as possible, and you can get up to 50 to 60% of the anomalies at that gestation. So this is one of the most important slides. If you are doing a nuchal scan, make sure that you get this image. But if you're not doing the nuchal scan and if you're depending on somebody's image, make sure that the picture which comes along with the report looks something like this. Because I had patients having nuchal report with images showing baby in prone position, baby in extended, and you can't even see what exactly NT is. So when you get the report, if it's high risk or low risk, doesn't matter. Look through the images. If the image is not looking something like this, please don't accept it. So it has to be mid-sagittal, which means the nasal bone tip is here. Nasal bone, you can see as equal sign, rectangular palate, and there should be a space in between. So this is mid-sagittal view. Neutral position means chin is not too close or too far away. Adequately zoomed, it should occupy 3/4 of the screen. Largest area is measured. and the caliper placement is inner to inner, thin clear membrane has to be visualized. Unless you do in this way, your detection rate is going to be abnormal. So always make sure that the image looks something like this. If it's not, the person who's doing the scan should go for the FMF free training and they have to acquire the skill and do it. If fetal NT increases with the crown drum length, what it means is don't please put it as a 2.5 mm arbitrary value. You can actually use the nomogram where you can put the NT against the crown drum length and see where exactly the NT is falling. The other thing is, when you send the patient for nuchal scan, please do not send them close to 11 weeks and 12 weeks, because the idea of doing nuchal scan is not just to do Down syndrome screening. We do look at the anatomy, as I mentioned earlier. So the anatomy visualization is going to be much better if you send the patient after 12 and a half weeks. 12 and a half to 13 weeks will be ideal so that you can do proper nuchal scan along with the anatomy evaluation. So when we do the anatomy evaluation, particular attention will be given for aneuploidy markers like atrioventricular septal defect, which is seen in Down syndrome, holoprosencephaly, which is seen in trisomy 13, cystic hygroma in Turner and Down syndrome. So all these markers will be looked for in the anatomy evaluation. And if you see any of these things, never do NIPT. You have to do invasive testing. I'm sure Anita is going to stress that again. Moving on to the biochemical screening. So another important thing, when you send the blood for biochemical testing or double marker, if a lab is just requesting you a chit of paper with a double marker, they're not validated. You have to give all this information to get the accurate detection rate. You have to give history, date of birth of the woman, which is maternal age, previous history of trisomies, race, gestational age, mode of conception, parity, whether she's single or twins, medical history, particularly diabetes, height and weight. Unless you provide all this information, they cannot calculate the multiples of median. And the risk is based on the corrected multiples of median for each parameter. So it is very important to give all this information. If they're happy just with the maternal age and the scan report, they are not quality controlled labs. So you have to choose a different lab. So what are the parameters? You know that in double marker, it's PAPE, which will be low, and HCG will be high. Cutoff is taken as less than 0.4 and HCG more than 2.5 mom. You don't have to know that because we do not take individual measurements. You put the maternal age, the NT value, the double marker, and final risk is considered as the actual result. And if you're doing quad screen, you add extra AFP and PLGF. As I said, it will improve the detection rate with the preeclampsia screening as well. And the cutoff in India, we take it as more than 1 in 250. So anything more than 1 in 250 is considered as high risk. Between 1 in 250 to 1 in 1000 is intermediate risk, and less than 1 in 1000 is considered as low risk. So when you get the report, please do not just look at the risk, whether it's high or low. Make sure that the calculation is based on crown drum length. It is not based on LMP. They have used FMF criteria, Fetal Medicine Foundation criteria. All the values are expressed as corrected MOM. And the software is, again, FMF approved. And the report should have age-related risk and final risk. Only if they're giving you in this format, you should accept that. Moving on to quadruple test. Quadruple test is only done if they are booked late or if they're presenting late, because we know that the detection rate of combined screening is 85%, whereas quadruple test is much lesser. So if you cannot do combined screening, of course, that is an option. Otherwise, always do first trimester screening if that is an option. And the time period is 31 to 52 millimeter. As I said earlier, not too early or not too late. Triple test is not done anymore. Now, another thing, when you get the report, instead of reading just the low risk and high risk, look at the corrected MOM. You know that all these markers are either placental markers or fetal markers. If they are unduly either high or low, there is an implication for fetal growth. So if the PAPA is less than 0.4 or PLGF is less than 0.45, HC is very high, AFP is very high, all this information is telling you that something is going on. So you have to categorize them as high risk and keep an eye on their growth, check for preeclampsia, IUGR and IUD. So I'm not trying to scare you, but always look at that. Even the NIPT, if the fetal fraction is less, there is an association with preeclampsia. I'm going to completely skip these slides because Anita is going to talk about that. Okay, what if NT is abnormal? We know that nuchal translucency has got association with the abnormal karyotype. It can have major congenital anomalies and fetal demise. As the NT increases, you can see that up to 3.5, the risk is not so high for chromosomal abnormality, but from 3.5 onwards, it steadily increases. It's the same story here with the major defects, the anomalies. And the commonest anomaly is cardiac anomaly. That's why we always insist that increased NT should have a fetal echo. The other anomalies are your congenital diaphragmatic hernia, exomphalos. There are so many other abnormalities which may be present in increased NT. This graph is very important because people generally say that if NT is high, they go for termination. But even up to 5.5 NT, there's a 50% chance that this baby could be completely normal. This scenario is particularly important when you have an IVF pregnancy. If the NT is high, please do not terminate. Sometimes it could be her last chance of having a baby. So make sure that you do all the tests and exclude all the possibilities, then continue the pregnancy. Or if there is a problem, she'll be happy to terminate. Just based on NT, please do not terminate. And bear in mind, if we do chromosome testing, if that is completely normal, if the NT is keeping on increasing or if it's very high, there is a 1% chance that it could be a non-chromosomal genetic syndrome like your urosopathies, your Noonan syndrome, congenital adrenal hyperplasia, etc. So in a nutshell, if NT is increased, how do you proceed? So you look at the NT. If it's between 95th to 99th centile or less than 3.5 mm, you have the option of doing either NIPT, combined screening, or CVS. You can choose any of these depending on what the patient wants. You can tell her that NIPT has got 99.5% detection, this is 85%, and this is 100%, which one you want, and you can talk to them about the pros and cons of each and the cost. If that is normal, you can do an anomaly scan and fetal echo at 20 weeks. And if the nuchal fold thickness is increasing, then you would do further testing. If NT is more than 99th centile or more than 3.5 mm, definitely you have to go for invasive testing. There is no role for NIPT at that point because it can miss up to 20% of the chromosomal abnormalities, because NIPT is looking for only 5 chromosomal abnormalities, and that too, it is not 99.5% for all the aneuploidies. Only for Down syndrome, you have 99.5%, and it will miss all the microdeletion, duplication, etc. So if the fetus is abnormal or the NT is very high, always go for invasive testing. If they are opting for termination, because his NT is very high, like 8 or 10, if they're opting for termination, you can tell them that they should either have CVS or products of consumption sent for either array or chromosome testing and DNA saving, so that we can predict the diagnosis, identify the diagnosis, and predict future recurrence. So as I said, an IPT is not good for NT more than 3.5. Any anomaly or high NT, even karyotyping is not sufficient because it can miss up to 10% of the microdeletion, duplication, and other chromosomal problems. So always do array for fetal anomalies and high NT. Increased NT, normal chromosome, what next? This is a dilemma. Like, you expect something to come back as abnormal, everything is normal, what next? So if it was very high, I would call them at 16 weeks for early anatomy evaluation and a cardiac evaluation. Then and again at 20 weeks, you look at the anatomy thoroughly. If that is all normal, keep an eye on the growth. If the new NT is keeping on increasing, or if some anomalies come across, then you can consider doing clinical exome from the saved DNA of your CVS or amnio sample. What about the other markers? If ductus venosus and tricuspid regurgitation, if any of the markers are present, you can follow the same protocol for screening, like either do combined screening or NIPT, but do a fetal echo as well to make sure that you're not missing any cardiac anomalies. Any major anomalies, you will do CVS and microarray and DNA saving if they're going for termination. So combined test, which is NT-HCG PAPA plus maternal age. Less than 1 in 1,000 is low risk, no further testing. More than 1 in 100, very high risk. Definitely invasive testing and array or karyotype, depending on why it is abnormal. 1 in 250 to 1 in 1,000 is intermediate. You can do NIPT. If it's 1 in 100 to 1 in 250, either NIPT or amniocentesis, you can discuss the pros and cons. Never do quadruple test if the combined screening is abnormal. You all read in your textbook that you can do that. That's because of something called integrated test. We do not, in our labs, do not do integration. So it's individual values and it will not take you anywhere. If that quadruple test comes back as normal, we don't know which one to trust. So you're losing time. So please do not do quadruple test if it's abnormal. You can do NIPT, provided it is age-related or biochemistry-related high risk. And if the NT is normal and no anomalies, of course, you can do NIPT. So that's about the double marker and the biochemistry. Now we'll move on to the next thing, which is soft marker. So second trimester ultrasound markers. So the common ones are given here. The bold ones are the one with high association. So soft markers are basically ultrasound findings which are not structural abnormality by itself, but it has got association with aneuploidy. So that is why you're looking for that. The ventriculomegaly, absent nasal bone, all these bold ones have got higher association. The weak ones are intracardiac echogenic focus, echogenic bowel, etc. So depending on the association or likelihood ratio, you would decide what test to do if you see these findings in the ultrasound scan. So findings like echogenic intracardiac focus, choroid plexus cyst, echogenic bowel, or mild dilatation renal pelvis, if they had a combined screening and if that is low risk, you do not have to do any testing from aneuploidy perspective. For echogenic bowel, not for aneuploidy, but as a differential diagnosis, you could have future bowel problems, growth restrictions, congenital infection, etc. So you need to do workup for that. So you'll do TOT screening, you will follow them up for growth and bowel pathology. If it's dilated renal pelvis, it can progress. So 85% of them will come back to normal. But if that progresses, you need to organize postnatal ultrasounds. So you look at them again at 32 weeks and check whether this is progressing or not. What about the other markers? If it's absent nasal bone or ventriculomegaly, increased nuchal fold or ARSA, they have got higher association with the Down syndrome. So you would suggest doing a further testing like your amniocentesis and microarray. Particularly ventriculomegaly and nuchal edema, I would consider microarray, not just karyotyping, because it has got association with many conditions. So this particular, you can actually take a screenshot of this. This is the management based on the likelihood ratio of each soft marker. What do we generally do? I've already mentioned that here. The one thing which I haven't mentioned is the short femur and humerus, which is a daily agony for me at the moment. If you see short femur or short humerus, you need to do thorough skeletal survey and make sure that you're not dealing with growth restriction or skeletal dysplasia, because Down syndrome presenting exclusively as short femur and humerus is not so high.